Hello, welcome to the Curo Conversations online module. I'm Donnie Wickline. I'm an ER physician in Greensboro and also the Medical Director of Patient Experience. Thank you for joining us today. Curo is our conversation model that we adapted from Atrium Health. Curo has been in practice in the Cone Health system for over 3 years with hundreds of providers undergoing this training. We've received tremendous feedback over the past several years, and we feel that this is a very valuable tool that we would like to impart to all providers in the health system. And thanks again for joining us. Today, we'd like to help providers develop effective communication skills using the model. I'd like to review opportunities and techniques, benefits, and challenges of using the model. And by the end of all of this, we'd like that you be able to do at least one of the following. State the 4 elements of the Curo model, to demonstrate at least one behavior within the model, and demonstrate and determine common challenges to using the model and develop solutions to those challenges. You're probably asking yourself, what's in it for me? Why am I sitting down, looking at the computer, listening to this guy speak when I could be outside playing golf or doing some other fun activity? Well, that's a good question. However, we do feel that there are some valuable aspects to this that you'll be glad that you joined. Think back through all your various schooling, fellowships, residencies. You had to have a baseline of communication to get through those, correct? However, it's probably been quite a while since you've actually worked on those skills. We feel that Curo, when used correctly, can enhance those skills, sharpen those tools, and take your communication to another level. Having said that, if your communication is improving, then more than likely you're going to be relating to your patients in a much more effective way. And if you're relating to your patients in a much more effective way, you're probably having a better work day. You're probably leaving happier. You're probably leaving your job feeling like that you accomplished a lot more than you were previously. Let's take a minute just to talk about surveys. Of note, this is not something that we talk about a lot or dwell on, but we do think it's fair game to at least know what patients are being asked. Think about the last time you took your car in to get serviced, or you bought a package from Amazon. Did you get a survey? Probably did, either an email, text. Every once in a while you'll get one in the mail. Well, the same goes for healthcare. Whether you work as outpatient, inpatient, surgical, medical, pediatric, it doesn't matter. Your patients are getting some sort of survey asking about their experience. Now, this can include their experience with your nursing staff, your front desk staff, the quality of the healthcare facility, but there are certain domains that pertain to providers and physicians. This happens to be the CAP survey, which may not be the one for your particular specialty. However, all the questions are fairly the same. Did the doctor treat you with respect and courtesy? Did they listen to you carefully? Did they explain it the way you understand? You may never realize that your patients are being asked those questions. Well, now you do. And it's also good to kind of know what's on those. But it's also good to know that by sitting down today and learning Curo, a lot of the things we review in Curo will actually help address those questions. We always go over this slide in every Curo session because it's that important. Look at the gap between this bar graph between physician on the yellow side and the patient on the white side. This is a study from 2010 that discussed the communication discrepancies between physicians and hospitalized patients. You'll see that it's quite a gap there. And what they did is they took physicians and their patients and they asked about the fears and anxieties from your patients. And what they found is that when they asked the physicians, they felt that they had addressed all the fears and anxieties that their patients had. Whereas less than half of those patients felt that truly all their fears and anxieties were addressed. You're probably asking, well, how'd that happen? Why aren't they addressing everything, even though the physicians felt that they did? It's likely multifactorial, but in my experience in the emergency department, the motivations for visits aren't always what they seem. For example, if I see someone for chest pain, I may just assume the patient wants to be admitted, have a full workup, rule everything out. But that assumption is usually wrong, or only part of the way. They may be there just because their family forced them to go, and they may just want some reassurance. They may be worried that they have an underlying health condition that may prevent them from working and providing for their family. And that may not be something that came up in your initial interview. What we're hoping is that we can take this Curo model and apply it to our patients and help bridge that gap and make that bar graph look a little bit more equal than it is now. Let's talk about stress. Patient stress comes from a variety of places. The diagnosis, if they were just diagnosed with cancer, certainly pain, worry, fear of the diagnosis. Am I going to live? Well, who's going to take care of my family? Those are all things that are wrapped up in the diagnosis. Then there's stress about the treatment. Is it going to hurt? Is there going to be side effects? How much is it going to cost? Can I afford it? Worrying about all the treatment that they could be undergoing. And then it's the defects in the care and the service that they experience. This doesn't necessarily mean that something was done wrong, but we live in an imperfect world, and defects and issues will pop up. Examples of this would be a wait time. I work in the emergency department. I know a thing or two about wait times. They're very challenging to overcome. Poor communication, lack of empathy and understanding. We cannot control everything as providers. It's very hard for me to control the wait times in the emergency department. I can't control when someone's in a traumatic accident. However, what I can control is what I'm bringing to the table to the patient each time. If I walk into that room and all I'm worried about is the wait time and how many people are waiting to be seen and not the patient in front of me, I'm likely to overlook important details or maybe not dedicate the amount of time that patient requires. I can control the communication, I can control the empathy I'm displaying, and I can control understanding the patient. We definitely need to talk about stress on the provider side. Although this list is not all-inclusive, it is very similar to what you'll see in surveys of physicians, usually done on a yearly basis. Productivity expectations are a huge stress for providers. Performance metrics, once you think you're doing well and hit one metric, they turn around and set the goal even harder to get. Poor work-life balance, that can be very challenging, balancing your family life as well as maintaining a good job at work. Reimbursement models, those are way out of our control generally. Payment structures, and generally the loss of autonomy as medicine is adapted in the 21st century. These are all stresses that we all face. Some are in our control, others are not. The main thing is that we recognize that it's there and try to find strategies to deal with it in the best way that we can. Let's move on to the main portion of our presentation. Curo, which means to care for in Latin, was adapted from Atrium Health over 3 years ago. It was brought to Cone Health and piloted with the emergency department and hospitalist physicians, and it was a great success. We have since taught this throughout the health system with hundreds of providers, and we feel it is a valuable tool that all providers should undergo. We'll take each letter step by step and dive deep and talk about each one and how we can add this to our daily practice. Let's kick this off by discussing connect, the C portion. You want to convey value, respect, and concern. You want to assess the emotional state of the patient. You want to set a shared agenda and then reassure the patient. You'll see this list may seem basic to you, and you may already be incorporating this, and if so, that's excellent. However, we feel it is important to have a list to keep it systematic so we don't miss anything. Before you even see the patient, first, make sure you're reviewing why the patient's even there before you even go into the room. That way you have some background. You may already be doing this. Take a deep breath and knock on the door. Just like you wouldn't walk into your friend's house without knocking or ringing the doorbell, you should probably knock and wait to be allowed to enter a patient's room. Patients may have been waiting a while in the waiting room around people they aren't familiar with, and they find that the patient room might be their personal space where they're decompressing. It's important to give them a few seconds before you enter the room. When you enter the room, always try to wash your hands, whether with gel or a sink if possible. That way they know that their health and cleanliness is very important. You can greet with a smile, and if appropriate, you can handshake. And definitely introduce yourself and anybody who's in the room. If you're coming in with a team, a nurse, or a tech, it's important to address them as well and manage them up if you can. If it's a nurse that you've had a long relationship with, say, hey, this is nurse so-and-so. We've worked together for several years. She's the best in the business. We're both going to be taking good care of you today. Ideally, the next step would be to sit down and a relatively close location to the patient if a chair is available. Sometimes chairs are not available, but if they are, definitely sit down, and we'll talk more about that in a moment. If possible, make a personal connection, or you may already know the patient from a previous visit. You can talk about something that you've already discussed, or if they're wearing a sports team that you like, you can always bring that up just to sort of take a minute to make a connection that's non-medical. Generally, the patient is there with a list of concerns, and so you can start sort of open-ended questions about those. For example, I see that you've been having some chest pain recently. I was reading the chart. What has been triggering that chest pain? And that can start the conversation. Once the conversation is going along, you can start talking about a shared agenda between you and the patient. Medicine is moving away from the paternalistic model where I'm the physician and this is what we should do, to a shared model of shared decision making. To better understand the C portion of Curo, let's review a vignette. Your patient is a 35-year-old female presenting with chest pain. She reports she's had the pain on and off for up to a week, and it seems to be worsening. She's short of breath with her symptoms, and it seems to be worse at night. She also recalls having a tremendous amount of stress with work and family, and she can never find any time for herself. She has no other medical problems. However, she appears anxious, distracted, and makes very poor eye contact. Also, she's been waiting in your office for over an hour. Taking a systematic approach to this patient, knock on the door and make sure you wait before entering to ensure that she's ready for you. As always, hand hygiene is a must, whether with gelling or washing your hands. Make sure you greet the patient and anybody that might be with her. And make sure you sit down as soon as you can and make that personal connection. Because she's been waiting, she's probably frustrated and would like to speak her mind, and so this is the time to let her do that. Let's review the importance of sitting in the patient encounter. This graph is a visual representation of a study from several years ago that asked patients a simple question: how long was your physician at the bedside? What they did was they took physicians and they had them either sit and stand, and then asked the patients how long they felt those physicians were at the bedside. What they found is that just by the simple act of sitting, the patients perceived that the physicians were at the bedside much longer than in reality. In fact, the physicians were actually at the bedside a little bit longer when standing. However, the patients did not perceive it that way. As this shows, and what many other providers will tell you, is that sitting is a powerful tool to really connect with our patients. One thing I always talk about when I'm presenting Curo is that I'm unable to create more time. That's just one gift I do not have. However, what I can do is help give strategies on how you can effectively manage your time. I hear this a lot when presenting Curos, that I don't have enough time. How can I fit all this into my busy day when I have an office full of patients to see each day? And these are all very fair questions, and something that all providers go through at some point. However, simple acts of compassion actually don't take a lot of time. This study, which was actually from 1999, shows that a physician's expression of enhanced compassion only took 40 seconds. And what they found is when physicians started showing that enhanced compassion, the patient's fears and anxieties started to decrease. So, as I said, I can't create more time for you, but I can give you strategies and tips on how to effectively manage that time. And I feel that, if you keep this in mind, that you can actually help alleviate fears and anxieties with just 30 to 40 seconds. That can be a very powerful tool that you can use throughout your patient encounters. Let's have a deeper dive into communication and its components. I really like this quote by Peter Drucker. The most important thing in communication is hearing what isn't said. This is extremely important when it comes to patient encounters, because a lot of what patients are learning about us and what you're communicating isn't necessarily the exact words that are leaving your mouth. So let's dive into that a little bit deeper here. First up, let's talk about body language. This is something the patient's picking up on almost upon arrival to the room. Are you looking rushed? Are you looking tired? Are you looking exhausted? Are you looking like you want to be somewhere else? Are you looking engaged? Are you looking excited? These are all things that the patients can read into pretty quickly. It also goes both ways. You can read into the patient's well-being as well in terms of the body language. If the chief complaint was, crushing substernal chest pain, you walk in and the patient's, FaceTiming with family or watching TV and looks relaxed, that also can go both ways. But having said that, how much do you think body language plays a role? Well, actually quite a bit, over half, up to 55% of body language, of your communication comes from your body language. So keep that in mind as you're entering your room. And just a quick reminder, before you enter that room, maybe just take a second, take a deep breath, try to clear your mind and try to focus on the patient at hand rather than all those patients that may be waiting in your office or in your emergency department or you need a round on as an inpatient. Let's move on to the paraverbals or tone of voice. So what does this mean? Well, this is what I like to say is it's not what you said, it's how you said it. So it may not necessarily be anything wrong with the words that you're saying, but it's how those words are leaving your mouth. So a good example is how we interact with pets. If you're a pet lover or have a dog, generally they are very good at determining your mood and how things are going just by the way you're speaking. If you're speaking in baby tones to them, they react very well to that. Or if you're yelling and being very stern, it could be the same words, just the way you're saying it is different, and you can see that in your dog, whether they wag their tail, if they put their tail between their legs, if they run away from you. They're masters at determining our mood just by the tone of our voice. And so can our patients. They can also be very attuned in how you're delivering to them, and so how you're delivering it. And that's almost 38% of total communication comes from paraverbals. And then finally, words are only about 7%. So as one of our other facilitators likes to say, the words are where you went to medical school for. So the knowledge, the vocabulary, all that comes from your medical training. But unfortunately, less than 10% of that actually matters in terms of communication. It's how it's been delivered, and it's how it sounds to the patient. So let's move on to the U of Curo. So this is the part where you want to ask open-ended questions to begin the narrative. And a lot of providers like to point out that if they have their patients speak uninterrupted, they may never stop talking. And though there are some rare patients that's the case, most patients actually, I find, don't speak long enough. And so a lot of times I'll need to use verbal continuers like, okay, tell me more about that, or what else happened. Really try not to interrupt. One thing physicians do very well is interrupt other people. And a variety of studies have shown this, but some have shown that sometimes physicians interrupt within the first 18 seconds. So in terms of that, put yourself in the shoes of the patient. If you've been waiting for several hours with pain that you've never had before, or concern that you've never had before, and you get interrupted within the first 20 seconds, you're going to be quite upset about that, as you should be. And that's why our patients would get upset if you interrupt them in that first 15 to 20 seconds. So if at all possible, in a non-emergent setting, really try not to interrupt the patient unless you absolutely have to. Definitely want to use reflective listening because this tells the patient that you've been listening, and it reflects back to what they've been saying, but also allows you to gather your thoughts and also sort of prioritize what seems to be most important. So for this lady, you would say, I hear you've been having some chest pain. It sounds like it's really concerning you. It seems to be worse walking upstairs, improve with rest. And you've had a great deal of stress on your hands. Is that correct? And that's a good way for you to reflect back to the patient. You want to acknowledge their emotions and ease anxiety with empathy. So if they're very upset, crying, tearful, appear anxious, you definitely want to acknowledge that. And then just give some reassurance. Like, we're going to work on this together. We're going to work hard to figure this out. And I'm not saying to make empty promises or grand promises of everything's going to be okay, or we're going to take care of everything. But it is appropriate to say we're going to work on this together, and I'm going to try the hardest I can to figure out what's going on. So for this patient, how will you encourage her to tell her story? Will you let her to speak uninterrupted? How will you demonstrate you're listening to her? Will you use that reflective listening to get back to her? And then really pick up on those emotions, a lot of those nonverbals. How is her body language? Does she look anxious? Is she moving around the chair a lot? Does she seem very, restless? And what's the sound of her voice? How are things being conveyed? You definitely want to pick up on all of that. as you are moving along through the history. All right, let's move to reveal and relate, the R portion of Curo. This is arguably the most important portion of Curo because this is where patient education, follow-up planning is all discussed. You want to make sure things are presented in a clear and concise manner. That way patient is following along and is not distracted. If you are distracted, if you have pages going off, if you have a urgent phone call to make, step out, do those tasks, and come back, because this is the part you do not want to rush through or get wrong. You want to make sure you're checking for understanding. You want to speak slowly, provide very small chunks of information at a time, and just describe the options that patients may have. Just because the patient came in with chest pain and you assume they want to be admitted, that may not be the case. I'm often shocked by patients who come in for fairly emergent complaints who'd rather go home and work it up as an outpatient or follow up. And if the patient clearly understands the risks of going home, if they are able to make their own decisions, then sometimes that's the path you'll take. So I just can't assume that they want to do something when actually they have another agenda and they're willing to work as an outpatient to take care of it or take that risk. You want to make sure you're identifying the main issue. You want to make sure that you're addressing what the patient needs to do and why it's important for them. So for our patient, you say, hey, you've had some chest pain. We've ruled some things out today. I want you to follow up within a week with cardiology. And it's very important for you to do that because I want to make sure you get the best care possible and make sure there's no underlying heart problems that's causing this. That would be an example of using ASME 3. And then teach back, which is very important and probably the most important part of reveal and relate. That's where you have the patient restate back exactly what you told them. And that way you're going to identify any gaps, because a lot of times patients will sort of go along with what you're saying and tell you that they understood everything, but in actuality they were unable to do that. And so let's talk about some strategies on how to do that. You can rephrase the information. I do this quite a bit, where I will talk about key points of when to return to the emergency department, and I'll rephrase it a few different ways to see if the patient is still following along. If possible, draw a picture if it's helpful. So I do this for a lot of abdominal complaints or any sort of chest pain complaints. I find pictures or showing pictures of like x-rays or CT scans, or that can really help connect the patient to what's going on and make that connection in their mind so they don't forget. You want to make sure you're limiting things to 2 or 3 points if possible. Certainly defining the acronyms. Much like when I go to the mechanic and they're throwing out a lot of terms I don't understand, I prefer them to slow down and define those so I don't get ripped off. The same thing can happen in the emergency department. You want to make sure CT and X-ray and MRI are all kind of lumped together in patients' minds. So it's important to explain what those are and what the acronyms mean. Certainly want to use a caring tone of voice and not belittle the patient. It's unlikely you're doing this. However, just keep that in mind. And you want to make sure that they don't feel ashamed if they don't understand it on the first go around. Much like I don't understand much about my car when I go in, they're not going to understand the first time that perhaps they need to get a follow-up CT scan or a follow-up with a cardiologist, or why that's important. And so it's okay to have some grace and patience and just allow them to process the information. Another thing you can do is, hey, I know your family's been waiting on you and been texting in about questions. What are you going to tell them today? What are the top 3 things you're going to tell them you're going to do in follow-up? Because what this does, it drives home the importance of communicating with family, but it also serves to the patient, the family, that actually something was done. There's nothing worse than a patient having an 8-hour ER stay and being discharged, and they're telling their family nothing happened. Well, everything happened. We did labs, we did urinalysis, we did CT imaging, and although everything looked normal or nothing was abnormal, it's important to narrate through that so they understand why that was done, and just so we get away from the phrase, oh, well, they didn't do nothing. Well, we did a lot, and here's what you did, and here's what we ruled out, and here's what I'd like you to do as a next step. And a lot of times that sort of conversation, either with family at bedside, via the phone, or what the patient's going to tell the family and friends, can actually be very helpful in realizing, in giving reassurance to the patient. So let's go back to our patient in the vignette with chest pain. Let's put yourself in the mindset of how you're going to speak to her with reveal and relate and teach back. You first want to acknowledge the current emotional state. If the patient is still very distraught, upset, tearful, and they may have just gotten off the phone with a family member and not really in that space yet to talk, then take the time to come back, because it's much better to take that time, come back when they're ready, rather than force feeding it to someone who's not ready and then it'll all be lost. You want to make sure you're pausing and checking for understanding. Hey, look, your chest X-ray was normal, but let's talk a little bit more about that. That means there's no signs of any pneumonia, no signs of infection, no signs of collapsed lung. And so those are ways to go beyond just saying your tests are normal. And certainly have any questions about that. You want to make sure that you're teaching back. This encourages patients to restate in their own words. So, hey, I just gave you a bunch of information about our testing. What are you going to tell your family when you leave here about some of the tests we did? And be like, I've asked you to follow up with your primary care doctor in a week. What are some things you're going to talk to your primary care doctor about? Those are ways for the patients to, in a non-confrontational way, go over their workup and what the next steps are. This is also an important time to use one final open-ended question. And this is, what I like to say is this actually helps prevent those questions when you leave and those after you leave or when you're at the door. Because if the patient still has questions but doesn't feel like they've had the space to ask them, they will come up before they leave your department, your hospital, or your office. And I'd much rather address those head on rather than address those 10 minutes later when I've moved on to the next patient. So as hard as it may be, that final time I typically will ask, what other questions or concerns do you have before you go? And a lot of times it's no, and there's not much, or they don't have any other questions. Which is good. However, it does give them that space, that open-ended space. Because if you say, do you have any other questions? Well, that forces the patient to do a yes or no. And that typically, they're probably going to say no because they realize that you're very busy and don't want to take up your time. Or if you ask it, do you have any questions while you're standing by the door? That's a point where your body language is saying, I don't want an answer and I don't want to ask you this question. And so if you can do that while sitting and have that open-ended question, that will help kind of clear the air and allow the patient to have any final questions and make sure no confusion has set in about the plan. So let's go back to our patient in the vignette with chest pain. Let's put yourself in the mindset of how you're going to speak to her with reveal and relate and teach back. You first want to acknowledge the current emotional state. If the patient is still very distraught, upset, tearful, and they may have just gotten off the phone with a family member and not really in that space yet to talk, then take the time to come back. Because it's much better to take that time, come back when they're ready, rather than force feeding it to someone who's not ready and then it'll all be lost. You want to make sure you're pausing and checking for understanding. Hey, look, your chest X-ray was normal, but let's talk a little bit more about that. That means there's no signs of any pneumonia, no signs of infection, no signs of collapsed lung. And so those are ways to go beyond just saying your tests are normal. And certainly have any questions about that. You want to make sure that you're teaching back. This encourages patients to restate in their own words. So, hey, I just gave you a bunch of information about our testing. What are you going to tell your family when you leave here about some of the tests we did? And be like, I've asked you to follow up with your primary care doctor in a week. What are some things you're going to talk to your primary care doctor about? Those are ways for the patients to, in a non-confrontational way, go over their workup and what the next steps are. This is also an important time to use one final open-ended question. And this is, what I like to say is this actually helps prevent those questions when you leave and those after you leave or when you're at the door. Because if the patient still has questions but doesn't feel like they've had the space to ask them, they will come up before they leave your department, your hospital, or your office. And I'd much rather address those head on rather than address those 10 minutes later when I've moved on to the next patient. So as hard as it may be, that final time I typically will ask, what other questions or concerns do you have before you go? And a lot of times it's no, and there's not much, or they don't have any other questions, which is good. However, it does give them that space, that open-ended space. Because if you say, do you have any other questions? Well, that forces the patient to do a yes or no. And that typically, they're probably going to say no because they realize that you're very busy and don't want to take up your time. Or if you ask it, do you have any questions while you're standing by the door? That's a point where your body language is saying, I don't want an answer and I don't want to ask you this question. And so if you can do that while sitting and have that open-ended question, that will help kind of clear the air and allow the patient to have any final questions and make sure no confusion has set in about the plan. And finally, we'll move on to O, which is the outcomes. This isn't necessarily an opportunity that you would speak to the patient, but this is more just, well, what does all this do for us? What does enacting the Curo model help with? Well, for the patient side, certainly if the patient came in stressed and worried and you are implementing this model and you feel like you really made a connection, they're probably going to have a lot of reduced stress. If they're reduced stress, they probably trust you more. They're probably more likely to follow your instructions. They'll definitely trust you more if you made that connection. They'll probably follow the treatment guidelines, and hopefully they'll have better management of any chronic diseases they may have. And certainly for providers, I can't guarantee that all of these things will happen. I do think this is a nice bulleted list, but I can't guarantee that. But I do feel that if you commit to Curo, commit to making those connections with your patients, you're going to have a better work day, you're going to be less stressed out, and hopefully you're going to be more efficient and actually have lower cost of providing care because you're putting that investment in time in the history taking, and you may realize that a lot of the testing may not be necessary, or even hospitalization may not be necessary. So I do feel like this can be very helpful when it comes to that. Now, I'm an ER physician, and currently I only work at nighttime, so I realize that not every patient is amenable to this model. There's plenty of distractions, whether they're intoxicated, whether they have mental illness, whether they're just not the patient who would ever respond to this, and I get that, and I hear you that not every patient will respond to this. But I do feel that most patients just want our help and will respond very positively to enacting this model. And you may surprise yourself for patients who you think won't open up, or who seem standoffish, or who are guarded, may actually open up if you give them that space to speak and open up. And I really feel it can be a powerful way to connect with your patients. Would like to put a plug in for any shadowing opportunities. I have shadowed providers in their clinical settings to provide feedback on their interactions with patients. This is generally providers who've been through Curo, really liked it, really wanted to make sure it was hardwired in their practice, and just wanted some direct feedback. This is a very low stress exercise. I typically will see 2 to 3 patients with providers, take notes, and then go over some opportunities as well as things that you're already doing well. And for the most providers, they're already hardwiring this in their own way. It just is a few pointers here and there to help improve that experience. So if you're interested in this, feel free to contact me at any time, and I'd be happy to help you with that. Thank you for your time. I hope you enjoyed this presentation. If you have any direct feedback, I'd be happy to receive that as an email form. Or as I said previously, if you'd like any shadowing opportunities, feel free to email me and we can certainly get that arranged. Take care, and we hope that you learned a lot from this.